hear
take
that?
you down to the auditorium and give you a half an hour piano lesson. So that was when I started to play, was when I was about 6.
I started between my freshman and sophomore year of college as a nursing assistant. And when I graduated college, I was an activity director in a nursing facility. And then I went back to school and became a nursing home administrator. And as divine intervention would have it, I was fortunate enough to be selected to be the director when the Erie County residents established Serving Our Seniors.
In my life, I was raised by my great-grandparents. It was just seeing the difficulties of what they're going through, different struggles that they have. My personality is more so if someone's reaching out for help, then I want to help that person. And so when I started with Serving Our Seniors, that's what it was all about.
What's interesting about Serving Our Seniors is that we were started by a group of senior citizen activists that lived in Erie County, and it was spearheaded by probate court judge Jane Lucal at the time. And what she was seeing for her court were older people who were falling through the cracks. And our job as Serving Our Seniors, in her vision, was to create a one-stop shop, and we would address questions, problems, and concerns so that people of older age could maintain their independence.
As we age, and I didn't think it would happen to me, but it did, you slow down and you aren't able to do as much as you used to do.
I got the chair shortly after I moved here, and I had no way of getting out of the house. And then they got me that ramp out there now. Just being able to be on my own, is the best thing in the world.
A lot of times when you on a program, people treat you like second-class citizens. They didn't do that. He gave me what I wanted. He made sure that I was satisfied with what I had.
So we started with the Meals on Wheels. It just lightens our load, we don't have to worry about getting lunch because we know we're going to get a nice warm lunch in our meantime. Another thing, they helped me go to the doctor in Cleveland one time.
I mean, I knew that they delivered food, but I didn't know that they would help him with his hearing aids or, getting his teeth and taking him to the dentist. That, I think, was awesome.
Does a person need assistance with getting up in the morning, assistance with getting dressed, bathe? We can provide housekeeping services. We can provide the Meals on Wheels program. If a person has difficulty getting in and out of a home, we can provide a ramp to try to help that person get in and out. If a person has difficulty getting around and can't no longer drive, we provide transportation services. As long as the person is still independent and we can just help them get through their day, that's our whole mission and our whole point.
There's nothing like serving our seniors. Such caring people, and I know they have always taken care of me.
Oh, I'm very proud. I'm probably going to tear up. I don't know where that came from.
These people put their soul into helping to make sure that it comes out right. It's like it's personal for them.
Okay. It's almost nap time, isn't it? No, I like that video. I've been trying to show it before each forum just because I think it's a really good video. So can you all hear me in the back? I know I speak loud, just ask my daughter. But my name is Tina Elmlinger. I work with Serving Our Seniors. I wear a couple different hats at the office. This hat today is the Healthcare Advocate Trainer. So these forums are based around different questions and problems that have come to me in the office when I used to do healthcare advocate sessions, how to teach people to be their own healthcare advocate. So the questions that I'm doing with these forms, as you see in front of you, the next form is about falling, how it's not normal aging. So that's the next one coming up. There's going to be 2 each month through October. So if you get our magazine or don't get our magazine, call in or look for the press releases about the healthcare advocate forums coming up. So they're questions that people have brought to me and the hot topics that are out there. And obviously this is a hot topic today, and so I thank you for coming today. It's been kind of muggy outside. But yes, so I did put in front of you there the next forum. I'm going to have my daughter, who's going to be excited to pass out some more information here in a little bit. But I want to have the panel introduce themselves, and I have representatives from Fisher Titus and from Firelands, because I want you to realize that this observation and mission thing is not just Firelands Hospital, so I didn't want everybody to pick on them. So to let you know, it's nationwide. It's not just the area hospitals making these decisions. It's Medicare and it's the insurance companies. So I'll let you guys introduce yourself. So the microphones, yep, they're red when they're on, and if you want to turn them off during the conversation, you can, because unfortunately my voice carries. But I'll go ahead with Lori and have her introduce herself and what she does at Firelands.
Hi, I'm Lori Tyson, the Director of Patient Accounts at Firelands Regional Medical Center.
I'm Beth Cluding. I'm Director of Case Management at Firelands.
I'm Debbie Boroff, and I'm a Clinical Documentation Improvement Specialist at Fisher Titus Medical Center.
And I'm Jill Schaefer from Fisher Titus Medical Center, and I wear many hats, but one of the hats that I wear is I am OSHIP trained, the Ohio Senior Health Insurance Information Program. I'm the county coordinator for Huron County, and I also do it at Fisher Titus.
And Beth, I couldn't hear you.
Oh, I'm the Director of Case Management at the hospital at Firelands Regional Medical Center.
Oh, okay.
Do you need her to move the microphone a little closer? Okay. All right. She's got a smaller voice.
How's that?
That's good.
I've got my mom voice on. So I'm going to pass out some information. The information I'm passing out is already in the Medicare and You handbook, but I'm going to give you the scenarios. So Katie, if you want to help me. So we'll get talking about the observation versus admission. Does one of you want to explain exactly what observation and admission, what that actually means?
I can. Observation is when you come into the hospital and you are not quite sick enough to be considered inpatient, but yet they still want to monitor you for a short time, then they will admit you as observation. Insurance companies bill that as outpatient. So even though you're in the hospital, and many people think that they're a patient in the hospital, technically it's observation. Makes sense?
Observation back in the day used to mean, if anybody remembers, you're in the hospital for 24 hours and then you go home. So that is not the scenario anymore. So it depends on your status in the hospital as to what services you're going to be qualified for. Interrupt me if I'm wrong. What you'll be qualified for when you are discharged from the hospital. What your status, meaning are you inpatient or are you observation? So these are the scenarios in front of, I have them in front of you guys. So let's go with the first scenario. So, Lori, would you read the first scenario?
You're in the emergency department, also known as the ER, and then you're formally admitted to the hospital with a doctor's order.
Okay, so am I inpatient or outpatient? Okay,
Inpatient.
you're an inpatient. So what is the key words in that scenario to tell me that I'm an inpatient?
By the doctor's order.
Correct. So I'm formally admitted, right? That was the key words.
You have an inpatient order from the doctor.
So the doctor actually has to write down the order saying, I'm considering this patient an inpatient, they are admitted to the hospital, they're no longer observation. So what will Part A pay for?
The hospital stay.
The hospital stay. And what will Part B pay for?
The physicians. for your doctors.
Does everybody understand that, Part A and Part B? Does anybody here have a Medicare Advantage plan? Or you have a card that takes the place of your red, white, blue card?
I do, but it's not a typical Advantage plan. It's a specially negotiated plan between the employer and the insurance, and that's a whole different thing. It's not what people expect from an Advantage.
So it's kind of like an OPERS plan or a state
It's
teacher?
actually co-insurance. It's not a supplement. I do the same as before I went on Medicare. They pay 80%, I pay 20%.
Okay, gotcha. Because it's the same for Medicare Advantage plans, correct? Because they just take the place of the regular Medicare, traditional Medicare.
Most insurance companies follow along with Medicare's guidelines.
Okay, so for example, her insurance that she talked about, having like a privately owned insurance, that would follow the same guidelines as Medicare would, more than likely.
More than likely.
So she still needs to ask the question also, what am I when she's in the hospital, whether she's observation or inpatient?
Anytime that you're going to be staying in the hospital, I would always ask, am I inpatient or observation? That's the key. And it all depends on the doctor's order.
Okay. Yes.
Is the hospital required to tell you, or is the onus on you to ask?
Okay, so she asked, is the hospital required to tell you, or is it on you to ask that question, am I observation or admission? So go ahead, whoever wants to answer.
So at Firelands, we are required to tell you if you're a Medicare patient. So if you have Medicare, we would give you a Medicare observation letter.
And it's the same at Fisher Titus.
Gary.
I have Aetna Medicare Advantage, and I just went to a seminar put on by Aetna. I don't have any of that paperwork with me, but I swear they said, because the same subject got brought up there, and I swear they said that Medicare Advantage, Aetna Medicare Advantage, took care of outpatient, or took care of observation. Does anybody know that for sure?
That's true.
That's true?
They'll pay both your Part A and Part B benefits.
So his question was, he has Aetna Advantage plan, correct? Which takes the place of your traditional Medicare. And that will pay for your observation stay. Is that what you're saying?
And the doctors.
And the doctors.
Doctors.
Okay, so how is that different from traditional Medicare? The same?
The same. It just covers both your Part A and Part B
Part B.
benefit.
It does, but at a different rate. I mean, if you're Medicare and you have a supplemental, you might not have any co-pays. What I tell people with an Advantage plan, it's pay as you go. So when you go in the hospital, every time you have a co-pay that runs as high as $300 for days 1 through 5. A little bit different. I mean, you get the same benefits, but what you pay is different than if you were Medicare.
Well, there is a deductible. Once you reach that deductible, they pay everything.
Let me ask you this. Hang on one second, Jill, sorry. Is yours through a former employer?
That sounds good.
Yes, so it's a privately owned plan, which is a little different, where they give you a different, and you're shaking your head too. Kind of like how OPERS used to be, Ohio Public Employees Insurance, where they gave you like an allowance, or they gave you a deductible to meet, and then you didn't have co-pays after co-pay. But most people that don't have an employer, and again, correct me if I'm wrong, because I know these insurances better than I know my own, which is really bad. So most people that have a regular Medicare Advantage plan not owned by their former employer will have co-pays as you go. So there'll be co-pays for hospital stays, co-pays for x-rays, co-pays. But again, if it's under a former employer, then yes, you're gonna have a little different outlook like you do and like you do, okay? Did anybody have OPERS before? Yeah, okay. So you knew about you did the transition, you kind of had sticker shock, am I right? Yeah.
No? Did you go traditional?
I did.
Yeah.
With a supplement.
So-
Purchase a supplement.
So do you find that?
I have no co-pays.
Yeah, exactly.
No co-pays.
Where with Humana, OPERS Humana, you did.
Yeah.
Yeah.
Okay, good. Yes.
Yeah, I have a question. Now with STRS as I guess the Medicare Advantage. Okay, so I went in there, took myself to the hospital emergency room, and ended up getting admitted. And I had all these tests and everything for a day. And my bill was, at that time, $50 for an emergency room.
Okay.
That's all. And because I was considered observation, so while I was there, I had all these tests. So it ended up, the real bill from the hospital was like $5,000 or $6,000, but I paid $50. So I paid an emergency room. So I had to go to the hospital, and I'm still on observation, I guess.
Yours is probably negotiated differently. You know, where you have to pay $50 every time you go into the emergency room, but they must cover everything else then.
Yeah, I guess it must be.
Well, and again, you're state teacher, so you're privately owned insurance, which is gonna be a different category. And it's so confusing because everybody say, well, I have a Medicare Advantage plan, but then they're a retired teacher, so then I'm like, oh, then you're on a different, yeah, so prescription wise, you're different, everything, so
And
yeah.
I even called him, and I said, is this my bill? You know, I was there for
Right, yeah, I would be shocked too. I wouldn't have called, but I would have been shocked. Okay, so the first scenario, the key, I know you're coming in, Q, but I know you're gonna have a lot of questions.
Because I went to the county office before.
You did?
And so did I, and so did this other lady. Because
Really?
Jacob said that's where it was next to
Well,
the
Jacob, okay, well, now I know. I'll have to post it on everybody's forehead. Okay, so I apologize for that, really I do. I don't know, I don't know why, but he might not know there's 2 office buildings. He's young, I'll give him that. I'm more seasoned, I'm not old, so. So we're, the people that just walked in, we're doing the different scenarios that I have there in front of you. Hopefully you have them. So the first one we talked about being formally admitted. What is my status after that? So along that same category there, I know you guys don't have it, but Part D is on, it's not on that scenario, is it in front of you? So what does Part D pay? Of course, prescriptions. So if I'm admitted to the hospital, those medications will be billed to my Part D, and that depends on, you know, what, they're gonna be cheaper through the hospital than they are gonna be normally, but again, you may get a bill from your Part D insurance. So yes, if you have a separate Part D plan. Does yours look like that? No?
If you're inpatient.
Correct me wrong. If you're inpatient, how's it different?
There's no Part D. Part A pays for everything.
Part A pays, see, I'm wrong. I'm also awesome, I like to be wrong.
And if your observation on your Part D is, at least, unless Firelands does it differently, is that you have to pay for your drugs when you're observation, and then you can ask for reimbursement from your Part D. They're not gonna bill your Part D, the hospital's not.
Right, okay, that's where the.
That is the same at Firelands.
Good. Does that make sense? Yes, no, maybe. Okay, yeah, clear as mud. All right, so we'll go on to the next scenario. So Beth, if you want to read the next scenario.
You visit the ED and you're sent to the intensive care unit for close monitoring. Your doctor expects you will be sent home the next morning unless your condition worsens. Your condition resolves and you're sent home the next day.
So am I inpatient or outpatient? Outpatient observation, correct? And why is that?
Because of time frame, they don't anticipate a long length of stay. So when it's within that 24 hours, then they typically do observation.
There's also what they consider a severity of illness and an intensity of services. So meeting specific criteria in that severity of illness, meeting that intensity of services, the amount of treatments or interventions that they do medical, as well as an expected 2 midnight stay.
Okay, so she said the key word there, 2 midnights. So I can be observation for how long?
There's no set time frame as far as ours. We'd like to have you out within the 24 hours of your observation, but it's not like we kick you out the door. If you're not, then we just have to readjust on our end, but it doesn't affect you.
Okay.
You can be observation. We don't like it to exceed 48 hours, but you can be observation for a number of days. It goes back to that intensity of service and severity of illness as well. So just because you're in the hospital for 2 days, you're not meeting the criteria to be inpatient.
Yes.
I'm wondering factoring in determining, and maybe this is not something anyone here can answer, this might be something more a physician would have to answer, is any weight given to whether the person's home situation, whether there's a spouse there, whether there are children or other family members within the same community, or if that person is all alone. Does any of that factor in to whether someone might be kept for observation or admitted or sent home?
For us, we take it into account for whether or not you can be safely discharged home, because a safe discharge plan is what we would like. Whether or not that makes you an inpatient or an observation, it doesn't carry a lot of weight unless it was a planned procedure where the physician felt that you had enough risk factors. You were falling a lot at home, you didn't have anybody there to take care of you, and he believed that based on the risk and it was a planned procedure that you should come in and be an inpatient.
So that if you're there for a
same.
procedure as an observation and you determine you can't go home alone, you have to have 3 nights stay to go to a nursing home or skilled unit. Where's that play into it then?
Okay, so let's back up for a minute. Yeah. That's where it gets dicey.
I'm sorry,
Yeah, that's where it gets
that's
dicey.
an
So
issue.
her question was, what is the status when I need extra care? So if I have to go to a skilled unit, if I need more rehabilitation, if I need therapy, what is the criteria for me to be eligible for that? And what I mean by that is you have to be inpatient for so many nights, considered an inpatient, upon discharge in order to be eligible for those services.
If you have straight Medicare.
So if I don't have straight Medicare, then what?
Then it's up to your insurance company. We'll make a request and then they will determine. So if you have an Advantage plan, they'll do what we call pre-certification, where the facility will send information and ask permission to bring you into that facility and give you those services.
Okay. So how many nights as an inpatient do I have to be in order to be eligible to go to a rehab facility to have my knee strengthened? Does that make sense?
It depends on insurance. Like you said, if you have straight Medicare, then it's 3 midnights. If you have a different plan, then you need that insurance
It's
authorization.
negotiated. Okay. So
You could be there one night and we can make the request of your insurance and they would be, as long as you qualified and needed the therapy, they would probably okay it.
So if I'm on a Medicare Advantage plan, I have to have it black and white for me. If I'm on a Medicare Advantage plan, I might not have to meet the same criteria as a traditional Medicare patient.
Correct.
Does that make sense? I get a lot of deer in the headlights. Okay, so if go ahead, do you have a question?
I was just gonna say, I thought Advantage plan and a supplemental insurance were 2 different things.
They are.
Okay, so, but nobody's mentioned supplemental.
Well, supplemental goes with your traditional Medicare. So
Oh,
when we
okay.
talk about traditional Medicare, that's what we're talking about, correct?
Yes.
Because some people have just traditional Medicare. They don't have a supplement to piggyback onto their Medicare.
Okay.
So when we're talking traditional Medicare, we're referring to the supplements.
Okay, great, thank you.
Yeah, it's the insurance world. But the Medicare Advantage plans work a little differently because they pay one premium and it's not a privately owned insurance. Is it considered privately owned? They just take
it's
the
more
place.
closely aligned with the commercial insurance
Yes.
than it is with traditional Medicare.
So if I'm a traditional Medicare patient and I, again, have to go, how many midnights do I have to be in the hospital to be inpatient, to be eligible for rehabilitation?
In order to take advantage of a skilled nursing facility and have that be part of your Medicare benefits, it would be 3 midnights.
Okay, so 3 midnights. Now, do you mean actually midnight, or do you mean 24 hour to 24 hour to 24 hour? You mean actual,
Midnights.
the time, midnight? I know that's a stupid question, but that's been asked of me. Do you really mean midnight, or do you mean noon to noon? So it's actually midnight to midnight. So if I go in at 6 p.m. on a Wednesday night, and I have to stay over, that would be 1 midnight.
Correct.
The next one would be the next minute. Okay. I know that sounds detailed, but that's how I have to pan it out for me.
What about 11 p.m.?
What do you mean?
That's still.
Still
Same.
counts.
Hours.
Still counts.
So if I get
11:59.
discharged at 11:59, that's not a midnight. Go figure. Yeah. Yeah. Good old Medicare. Did you have a question?
Yes, no, you've said, you've referred to Medicare in two different ways. Straight Medicare and traditional, aren't those synonymous?
Well, we refer to it as Medicare Advantage plans, and we refer to them as traditional Medicare.
And I apologize, I used the two terms
Okay,
interchangeably.
because I was going to say, maybe she did use straight, yes.
Okay, great. Thank you.
Yes, I'm sorry. Because I used to use the word straight too, and somebody told me traditional, and that's where it stuck with me. So traditional straight Medicare is Medicare with a supplement or Medicare alone. And then Medicare Advantage is where you have the one, I always refer to it as the one card. The one card takes the place of the 3 cards. That's what I referred to as, so yeah. Okay, did you have a question, somebody I missed? Oh, there was a hand up. No, okay. So let's go to the third scenario. I'll have Debbie read this one.
You come to the ED with chest pain and the hospital keeps you for 2 nights. 1 night is spent in observation and the doctor writes an order for inpatient admission on the 2nd day.
So am I inpatient or outpatient?
The same.
Okay, what's the answer?
So you're outpatient for the first day and inpatient for the 2nd day once they wrote that order.
So what's the question you need to ask the 2nd day?
Why can't I be inpatient?
Or am I inpatient or outpatient? What's the question you need to ask the 3rd day you're in the hospital?
Why didn't you admit me the first?
Am I inpatient or outpatient? So the point is you need to ask the question or have your loved one ask the question so you know if you need services more after you leave, and whatever insurance you may have, you still need to ask the question, okay? Because it gets a little dicey there. But they have to tell you too, by the way. And again, if you're questioning what's going on, there's people like these women here that will answer those questions for you. Am I right?
Yes.
Yes, because it gets sticky. Yes.
Does a patient have a right at some point to just say, I want to be released now?
Yes. That's called AMA, Against Medical Advice.
Okay.
Is that what it's still called?
Yes.
Yes. You have the right to do that anytime during your hospital stay. Don't get me wrong. Anybody can leave anytime. It's happened. I've seen it
Yes.
many times.
We won't
Yes.
keep you prisoner.
The hospital's a real fun place to be. No, I'm just kidding. Okay, so what does Part A pay for in that scenario?
Your hospital stay.
Your inpatient stay.
Okay, so my inpatient stay, so it'll pay for my 2nd day? Am I right, Lori? You're giving me that look.
So with traditional Medicare, it would pay for the whole stay, observation and inpatient.
Okay.
Because Medicare has a rule that anything within 72 hours that's related to that inpatient stay has to be on the inpatient stay.
Will that first day count towards if I'm on traditional Medicare, will that first day count towards any type of
No.
rehabilitation that I would need afterwards?
It won't count as a night for
As
skilled.
an inpatient night, no. It won't count as a midnight.
Right, it's a good thing.
Okay. Does that make sense?
That makes more sense.
I keep looking at you, Gary. You nod your head when I still make sense. Okay. So what is Part B to pay for?
The inpatient physician.
The physicians.
The physicians, yes. Yes, so the physician whatever physicians come in to see you, that's what's covered.
For both days. For day
Yes.
1.
Because it's like.
Because B goes with A, in a sense. Whatever A pays for, B usually pays the other part. Am I right?
B pays for physicians.
Doctors, outpatient.
Okay. So Part D pays for what? Which is Part D, which is prescription insurance that I have separate. What does that pay for?
Prescriptions.
On the first day, it pays for. Will I get a bill for my Part D if I'm still observation that first day?
You only get a bill for Part D when you go to the pharmacy, you know, an outpatient pharmacy.
Okay.
You don't get it while you're in the hospital.
All right. Okay. Let's go to the 4th scenario.
You go to the hospital for outpatient surgery, but they keep you overnight for high blood pressure. Your doctor doesn't write an order to admit you as an inpatient. You go home the next day.
Am I inpatient or outpatient?
Outpatient.
Okay. And Part A pays for? Okay. Part B pays for? Doctors, physicians, and then Part D, prescriptions. No. But I may have to reimburse Part D.
Every time you go into the hospital, it's just beneficial to always bring your medicine bottles with you. Because if you're in observation, Part B doesn't pay for your drugs. So if you have brought your bottles in their original, or the meds in the original containers, some hospitals will allow those to be used instead of charging you for those prescriptions.
I will say Firelands does not request that you bring those so that you can take them when you're in the hospital. We would like to look at them to make sure that we get an appropriate list of medications that you're on. But we will have the pharmacy give medications to you and the nurse to administer those. But we use a separate charge master, so you're not paying $9 for an aspirin. You're paying a very reduced, it's 25 cents, so.
You cannot use your own if you bring them?
If it's something that the hospital carries, no, you cannot. It's a safety thing, so we want to make sure that we're providing you the safest care.
Fisher Titus does allow you to, but you have to bring in those original bottles, like Joe was saying, and once the pharmacist checks them all in, then the nurse will still give them to you, but they'll be your own meds, so then it saves you money.
I have a question. I have a situation where one of my medications is compounded, and I would probably be coming to Fireman's. How would you handle that situation?
So her question is, just to repeat for the video, is that she has a medication that's compounded, which is like it's either in a cream or powder form.
It's capsule.
It's a capsule, but it's compounded into the capsule. So her question is, at Firelands, because they won't allow her to bring her medicines, how would they do that with the compounded drug?
So if it's a medication that we don't have, but you still need, we would have you bring that in. The doctor would write an order for you to be allowed to take your own medication, and then we would send it to the pharmacist to have them make sure that that is what is written on the bottle, so that you could take your own.
Okay. Yes.
Yeah, I have a question. I had a friend who went to the hospital with her husband and brought the medicine along, but they were charged a dispensing fee. Gosh.
Have you ever heard of a dispensing fee if I bring my own medications and take them myself?
No.
Was that one of the area hospitals?
It was Fisher Titus. So she shouldn't have paid that bill.
Not that I'm aware of. I've never heard that before. Have you?
So I would definitely question them.
Yeah. Definitely something to dispute, because if they've never heard of it either, then it might have gotten thrown in there by accident, or who knows, so, yeah. Okay. Any other questions? Yes?
Yeah, so if Medicare or our supplement Part A doesn't pay the outpatient, are the patient charged and we have to pay the bill? If it's just observation?
So her question is, if Part A doesn't pay for observation, who gets billed that?
Part B pays it.
Part B.
Part B pays outpatient, Part A pays inpatient.
Okay. Thank
So
you.
observation's considered outpatient, so Part B would pay.
So if you have traditional Medicare and you have Part A, which everybody gets, and you didn't choose to elect a Part B, that's where you would get into trouble because you don't have any coverage.
But if we have Part B on our.
Correct.
Okay, thank you.
Okay. Yes?
The subject we're talking about today, 10 years ago, probably didn't come up because most people who went into the hospital, whether it's ER or however, ended up staying. Now, with Medicare and the hospitals, if they can kick you out, in a day? They do. So you got a different scenario today than what you used to have. So you have to be sharper, in other words, to know.
And that's exactly why we're here today.
That's right.
Yeah.
It's hard to do if you're
I've
unconscious.
experienced the problem, in other words, and I know where.
Okay.
where you're at.
You experienced the problem as in, what kind of problem did you experience?
Well, my wife, she was in the process of dementia and so on, and she fell, was entered the hospital early morning. And she stayed the first day she didn't respond to anything. And then the second day, she started to respond and got better, and they said she had to be out by, I forget, the evening sometime of the second day. Well, I didn't realize, in other words, that I had to find out whether she was admitted or not admitted.
Right.
So what happened, she went to, we found a nursing home for observation, in other words, where she could get therapy and so on and so forth. And that's where she went. And then I found out, in other words, I had bills after that.
Right, because she
So
was.
I learned the hard way, so to speak, but
Yeah.
it's history now.
Because she was considered observation or outpatient when she was discharged to that nursing facility, correct?
Right.
Yeah. So that's why we're having the subject, because the more you know, the better you'll do. And the fact is too, if you're here alone, you need to tell whoever's going to be with you in the hospital to let them know. Because I know if you're laying there in the emergency room, you're not feeling the greatest, the last thing to come to my mind is, am I observation or admission? The first thing that's going to come to my mind is, make me feel better. Or God, what's happening to me, right? So that's why I always tell everybody, and we talked about this, I think, in one healthcare advocate session that I had a couple years ago, was bringing a notebook with you so you know what's going on. Have people sign in, say, I'm here to, take your blood, this is my name, just so you know what's going on. A lot of people appreciate that. Some people don't want to have to do that, but because of the changing times and the way the world is, I think it's always a better idea to do that too, so that you can at least know what's going on. And if there's a language barrier with a doctor, because most of us will probably see a hospitalist and we won't see our regular physician in the hospital, there's a language barrier, sometimes that helps also. So yeah, so that's why we're having that conversation. Go ahead.
I was gonna say, I talk to a lot of people that are just going under Medicare, they're just turning 65. And what I tell them is you're not gonna remember all the fine details, but you gotta remember the two words. Am I inpatient or observation? And those are the things that you have to tell your loved ones. Say there's a difference. So if I go into the hospital, ask them what I am, and then they'll ask them to explain it to you. Because like I said, you're not gonna remember everything, but if you know that those two words mean something, and you pass that along, that helps.
Yes. Okay. Yes, Ben.
So can you demand to be admitted as an inpatient?
Can you command?
Demand.
To be an inpatient. Can you demand, maybe if you're Donald Trump? No. I don't even know if that'll go far for him, to be honest with you. But can you demand to be an inpatient if you're observation?
Unfortunately not. There's certain criteria to meet, and that's how they determine if you are inpatient or observation. And so it's not about, because the hospital, the patients, everybody would love the inpatient, and then we would never have any of these other issues. So it's based on on certain criteria, and it's not a simple, you have to have this. It depends on what the diagnosis is, what the treatments are, for them to determine if you are inpatient or observation.
So there's really nothing you can do about it. Whatever they suggest.
Well, you can have the conversation with your doctor. But again,
I think the message that everyone's trying to convey is just to be informed so that you know what to expect, so that you can prepare for what your plan should be when you're discharged. I think with the Advantage plans, the way that it works is you may demand in the emergency room to be inpatient, and your doctor may say, well, I'm not going to fight this, make him inpatient. But what we will then do is we will send a snapshot to your insurance company saying this is what's going on with this person, and they may say they don't meet inpatient criteria, make them observation. So you know, you can demand it, the doctor can say it, but then the insurance companies kind of come back and say, you don't meet the criteria to be, so make an observation.
Sorry. Wait, she has to answer her phone first. I'm just kidding. I'm kidding. Chris?
I know about Medicare review, if you're ready to discharge, so is there any request for a review of that decision
If
that you just mentioned?
A request for a review of the inpatient versus observation.
Yeah.
Medicare right. Oh, if you, I'm not sure if you're talking about your Medicare right to appeal. If you feel like you're being discharged from the hospital too soon, you do have the right to appeal your discharge.
Correct. And so that's one scenario, but I don't want to muddy the waters, but when you were talking about, so you're in the ER, you think you should stay, and they say, no, you don't meet criteria, you're going to remain observation. Is there any appeal process to that, in that time frame of that decision?
There is. So there's an opportunity for the physician to do a peer-to-peer with the physician at the insurance company. So the doctor who's taking care of you can call the doctor at your insurance company and say, this is why I think they need to be inpatient.
So if my loved one's in that ER room or the hospital room under observation, they're saying they're going to remain that, it would be you would ask the case manager to come help you.
Well, so that would take place prior to us even letting you know. So if it was denied by your insurance company, we would ask the doctor to call the peer-to-peer. Before we upset anybody, we exhaust our options.
So you've already asked them.
I was gonna say, I wanted to make one thing clear, and Lori, correct me if I'm incorrect, but if you have traditional Medicare and you have a supplemental that's pretty comprehensive, if you're under observation, under Part B, it's 80%, but your supplemental will pick up that 20%. The only thing that's different about inpatient and observation is your medications that make the big difference.
That's true.
So, I mean, it's not that you just have to understand that your medications are the thing that makes the biggest difference. And at Firelands, it's not really an issue if they give you the lowest price, but even if you have a supplemental, then you have to understand you're going to pay that price of those medicines. You know, or at some hospitals like Fisher Tice, we have you bring those in, and whether you pay a dispensing fee, I'm not sure, but we'll find out.
Yes.
One thing you may want to clear up, I'm a pharmacist from Bellevue Hospital, but I'm going to be 65 in December, so that's why I came. But this that medication business is just referred to your home medications. If you're getting IV antibiotics or IV cardiac drugs or anything like that, those would be covered.
Correct.
It's basically things that are considered self-administered medications. So anything you're on at home, or even if they change you from an IV antibiotic to a PO and or an oral antibiotic, that, then the oral antibiotic probably would not. Okay.
I know. And thanks for clarifying that. You're right.
Yes.
Who is the doctor that signs the order about being admitted? Is it your hospitalist or is it your primary care physician?
Hospitalist.
Whoever is your admitting or attending physician while you're in the hospital would be the one that signs the order.
And they don't really know your history. Right. That's one of the issues that I would have.
You're rent-a-docs.
They're rent-a-docs. Oh, God, thank God. None of them are here, are they?
Because we're rent-a-doc.
Okay, well.
They don't give me anything.
Well,
and
and
they're
that's.
there for 17 hours without pain medicine, without anything. And because a computer wasn't, you could run down a pharmacy and bring something up real fast.
Oh my.
Well, I think that that goes back to the intensity of service and the severity of illness that you have. So it could be any physician looking at that, and they should all be able to see those same things to make that determination. In addition, you have utilization review people. I'm not sure about Fisher Tice, but we have people who are looking at that to make sure that if you are meeting inpatient criteria, that we're capturing that, or if you're not meeting inpatient criteria, that we're notifying you.
Did I understand Jill to say that it really isn't that much money if you're admitted observation, or if you have traditional Medicare and a supplemental? Are you?
If you have a comprehensive supplemental, it's just these self-administered medications. And like you said, Beth, they, you know, an aspirin, I forgot what reference you used, but I mean, if it's, an aspirin isn't one, but I mean, if it's a medication that you give yourself at home, at the hospital, it's a little more pricey than it would be to buy your 30 days worth of pills under your Part D. But then you can always ask for reimbursement through your Part D, but you have to work through that yourself. And they're gonna reimburse at their price, not necessarily at what the hospital charged you.
Yeah, so is there really that big of a issue here if we're, no?
The big difference comes in when people don't have their home medications and they get that charge when they're observation. The other big difference that we see is, or not difference, but something that upsets patients is if they're observation and they don't have that qualifying stay and they need to go to rehab. Those are the biggest issues with observation versus inpatient.
Or like I said, if you did not purchase a Part B plan.
Yeah. See, I'm a member of a group, and I was encouraging those people to come to this. It seemed to be so important. And this one gal said, I was admitted observation and not admission, and I'm still paying my bill, and it was 2015. Well, I didn't ask her. Maybe she didn't have much of insurance other than.
She might not have. She might have had an Advantage plan that ran differently.
Oh.
Yeah, and that's why everybody's scenario is so different. So that's why you have to take in consideration, and just like the two people that I was talking to that have the employer-owned insurance, the Advantage plans through their former employer, because that's such a different ballgame than somebody that has a Medicare card, a supplemental, and a Part D card. You have to be savvy, and this kind of having these forums makes me let people, hopefully their light bulb comes on saying, okay, yes, I have to carry these with me all the time. I've got to know what, where I'm going from here. I mean, we all know what could happen an hour from now. An hour from now I could get in a car accident and I'm on Medicare, traditional Medicare, and break my hip. Then I may need to consider myself, hey, obviously I need to know.
You would be inpatient then.
That would be. I don't know. They do outpatient. They do outpatient hip replacement.
And your car insurance.
And your car insurance. You know what? I'm gonna test it. My husband would love me for that one. Yes. Okay. I'm not sure whose hand was first, but I'll pick you first in the back.
I was going to say that some of us back here are having
hearing. Okay. Okay. So a lot of the questions were coming up. Her last question was, why are we here talking about it? It doesn't seem like it's a problem, in a sense, which we talked about. It depends. The biggest problem that's come up is the gentleman next to you, his situation. Didn't know his wife was observation. She was to a skilled facility, and boom, So that's kind of the biggest conversation. Makes a difference if you have a separate Part D plan. That's what we talked about also. So yes, and then or self-administered medications is basically what we're picking on here. So yes, you had a question.
If you go AMA and you are an inpatient Medicare, does Medicare make you pick up the bill because you went AMA?
So her question is, if I leave against medical advice and I'm on Medicare, what will Medicare make me pay?
They'll process the claim.
Yeah, you would be accountable for whatever you would have been accountable for had you stayed and been discharged. I know that there are a lot of folks who, back in the day, they say if I leave AMA, my insurance won't pay for this day, and that I have not known that to be true in the 15 years that I've been doing this.
Yes. Okay, there's a question up here that was before him, so I'll let him answer or ask his question. Go ahead.
On this cost of medicines, I personally ran into this situation.
Okay.
And I don't know whether I had traditional or supplement or a
Advantage plan?
Advantage plan at the time.
Okay.
But it ended up, I had $168 in just my little handful of medicine. And so I kind of thought about this. Beth and I
Oh.
kind of looking at one another here. She wondered if I was probably gonna ask this question. But she did get it, to her credit, she did get it worked down, it was $62, which was still, I think I paid $9 for Cavendol, and it was a nickel a piece when I buy them at the pharmacy.
Yeah.
So, that can be a problem.
Yeah,
So,
yeah.
And in regard to that, now, somebody said that if your Part B would pick it up.
Your Part D, you can.
Part D.
Yeah, you can
Okay.
submit to your Part D to be reimbursed.
I don't have D with Medicare, I've got it on supplement. I have it.
Do you have an Advantage plan?
Advantage plan,
So you have it part of your Advantage plan. So you actually have prescription coverage.
yes.
You pay it.
So
Okay.
that should have been covered.
It's the same
back.
scenario, correct?
Well, I apparently didn't have that at the time, so
Yeah.
otherwise I would have pursued that.
Right. Because if you have an Advantage plan, most of you have a prescription package with that, right?
Most, yes.
Yes.
There's a few out there that don't.
Yes. So if you have traditional Medicare, that's where I come down where you have the 3 cards. You have the red, white, blue card, supplemental card that picks up the 20%, and then my separate prescription insurance. Because in my mind, I have to have it laid out like that, the card compared to 3 cards. So yeah, so if you didn't hear him in the back, he mentioned, did you hear everything he said? Good. I know his voice is low, easier to hear. Your question? You had a question, yes.
Yeah, different scenario. I have a life alert tag that I carry. And of course that will call in
Yes.
to the people that I have listed, in other words. Now, my family isn't close. I have one son that lives close, and of course he's on the program too, but if I have a problem, in other words, and he's traveled some, in other words, and is gone, and all I have is a neighbor or a friend, in other words, that could be with me when I'm transported to the hospital, and there's something that comes up that needs to be taken care of, what's the process and what's the situation at that point? Does the doctor have control, or what do we do?
So your question is basically you're on your own and you come into the emergency room, now what? Is that what you're asking?
No.
Okay, so now what, as in, are you unconscious? Are you just not aware of what's going on? What's happening with you?
Well, may not be unconscious, but in other words, not capable of probably making the decision.
Right, okay. So who would speak for you?
Yes.
So in Ohio, if you come into the hospital and you're not able to make decisions on your own, we're gonna look to see if you have any documents, like a power of attorney document on file. If you don't have those, then we're gonna go by the next of kin. So in Ohio, that would be your spouse. If your spouse is not there, that would be adult children. If we can't get a hold of any of those people, we just keep working our way down the line. Spouse, adult children, siblings, parents, and we're trying to find somebody who is related to you by blood or by adoption, so that they can help make decisions for you in the event that you can't make your own. If it's an emergency situation and your life is at risk, the physician doesn't need consent to do anything, because we always err on the side of, let's try to save you and we'll work it out later.
Well, that's what I do have family, in other words, that's distant. And it takes time, in other words, to contact those folks and so on. And that's what I was wondering, how you proceeded.
And then I would suggest that you choose the one that you think would be the most available.
Well, I do, in
Yeah.
other words, I have that list now, and, of course, power of attorney too, and so on. But if they're not available, say that, well, for instance, in the spring, my son travels to Arizona, spends the month of Arizona at the spring training out there. Well, it bothered me a little bit because he was my first contact, in other
Right.
words, if I have a problem. And then it goes down the list from neighbor to whatever, and eventually some of the family.
Try to notify him by telephone, and he could make decisions over the telephone.
Yeah, you don't have to be in person as long as we can get a hold of you.
His phone numbers
That
are
would be it,
available.
yeah.
So on that same line, does everybody have a medical emergency card they carry with them that has their medications, their emergency contacts? Okay, so you're gonna have one now. So.
Came prepared.
Yeah. We just got these made. Everybody has, go ahead, Joe. I'll let you go first.
My doctor told me that when he does lab work every 6 months, and be sure that everything is updated when you do that, so that if you go to the hospital, they have the correct phone numbers of your emergency contact and so forth.
Yes.
That's
Yes, that's
one way because of hospitalists and everything.
And that's the way to be your own healthcare advocate, is to keep up on that, especially with medications getting changed often. I know as a nurse back in the day, I appreciated when the medication list was updated. So did everyone else. I'll let you take one and pass it down. So these cards we had made up, everybody asked us about, I push and push about getting your medical emergency information, medication information, carrying it with you at all times. I push it enough that I'm sure a lot of people tell me to shut up in their mind. But we had these made, and then we worked with Ireland on this just to see universally what is actually needed. And again, it has on here medical emergency information, if you have a living will, if you have a healthcare power of attorney. If you do have those, they should be at the hospital that you normally go to and in your doctor's office. And then in the back is a long list there. You can put medications and then why you take the medications, doctor's name. So if you don't have one of these, I encourage you highly to fill one of these out and carry it with you at all times. That way, if you're alone, you're not able to speak for yourself, you're in a car accident, you break your hip. Just kidding. They have this in you. Because I know when I worked in the emergency room years ago, we did look in people's purses. I mean, do you guys remember doing that? Yeah, we looked in people's purses. To find somebody or to find out who they are. So if you have this and it's a red flag saying, oh yes, they have this, okay, let's call. I mean, it just is a time saver for you and for the medical professionals that you're working with. So I'm giving those out at all my healthcare forums because I just think it's a good thing. And I think the way the world is today, things happen so quickly, I think it's good to keep an eye on that. So yeah. So are we gonna go on to the next scenario? Okay, Lori, I'll let you read the last scenario. Yours is on the back out here in that group.
We actually already did this.
Oh, we did?
Sorry.
Okay, read it again.
Your doctor writes an order for you to be admitted as an inpatient, and the hospital later tells you to it's changing your status to outpatient. Your doctor must agree, and the hospital must tell you in writing, you're still a hospital patient before you're discharged. That's your hospital status, that your hospital status changed. Sorry about that.
Okay.
But we did talk
So
about
we
that a little
basically
bit,
have
yeah.
covered that scenario then as to that your hospital status has changed. I know at one hospital I was at, they kept a whiteboard in the room and they wrote on there what their status was. Does Firelands or Fisher Titus have that? The whiteboards?
We have a whiteboard, but we don't put on their
What
inpatient
their
or
status is,
observation,
okay.
but that's a good idea.
Well, I was surprised to see that, and I think it was a hospital in Toledo. My father-in-law was at, and I just looked, and of course I knew what it was, but they had the social worker's name. So has anybody been in the hospital where they've seen the whiteboards? Yeah, yeah. Okay. Did you find it helpful?
Yeah, my daughter in Columbus.
Okay, good. Yeah. I mean, like they listed the social worker, like I said, and I really liked that because then I knew who to talk to or who to ask for when I needed to ask for that. And of course, the nurses can always find out for you too, but it's a good retrieval of what's going on. So, okay. So other questions we have. So let's clarify. Somebody clarified 3 midnights. What does that mean again? I like you guys looking at me like, really?
If you're in the hospital and you need to go to a rehab facility and you want that covered by insurance, by Medicare, then you would need to have 3 midnights in the hospital prior to going.
Okay, and what happens if I don't have that status and I need extra care? I need to go to a skilled facility or?
Typically if you are in the hospital and we're waiting for, and you need to go to a rehab facility, then as long as you are inpatient, we keep you until you have your 3 midnights so that you can go to rehab and have insurance cover it. If your observation and it's not a situation where we're waiting on the authorization from insurance, then we work with you as far as if we're able to make you inpatient, if you have any kind of resources to help pay for rehab facility. We have case managers and social workers that work with you and try and come up with the best plan, because we want to discharge you home safely or to rehab.
I know that if you don't have a qualifying stay for your Medicare, your traditional Medicare to cover a skilled nursing facility, they will notify you of that and they will let you know what your options are. When we have folks who come in and let's say they were only here for a day, but they cannot go home because there's either nobody there or they can't take care of themselves at home, we will work with them to identify what facility they would like to go to. And if they go to a skilled facility with an observation rate, there are some facilities that will do it for about $200 a day. And they will give you the therapy that you need and bill your Part B Medicare for the therapy that you get, and you're just paying for the room and board.
We have it all clear? What questions do you have? What do we need to clarify?
Just also variable though, isn't it?
Well, it is, and the key is the questions you need to ask, right?
Right.
And we never had to ask questions before, as much as we do now, right? Believe me, I ask a lot of questions, just ask my daughter.
Well, and I think you can save yourself a lot of frustration by asking those questions before you get into the hospital from your insurance company. So if you ask your insurance company, what are my benefits and what is covered and what is my responsibility if this scenario happens or if this scenario happens, because then you can not worry about that when you should be worrying about getting better.
Yeah. Okay, yes.
You said that they should inform you whether you're gonna be an inpatient or observation. I have never had a doctor tell me that. I had to ask, but they never once told me. And when my husband was in, they admitted him. And I said, is he in for observation? Or they said, no, we will admit him. But nobody told me until I asked.
I think sometimes, I know at Fisher Titus, there's a form that you sign. One lets you know that you're observation, or if you're switched to inpatient and you have Medicare, then we have you sign a form. Sometimes people just sign it, and I've had people say that they weren't aware that they were changed, and so that's part of signing that form. So they should be having you sign that and explaining what that means for you.
Well, and I know at Firelands, within 24 hours, one of the case managers will come around and provide you with this Medicare observation letter, and I gave Tina a couple.
I just passed them out.
Oh, okay. So it explains what that means for you, what that's going to mean for you financially, what it means about your skilled facility right benefits, and then what it means for self-administered drugs. So that's one that the patients would sign, or the patient's representative would sign.
Yes.
Okay, what you just said, is that what everybody does? I mean, you got it within 24 hours, you said. Are there places that do, like you got like 1 hour to sign your life away before you even, anything's explained? I mean, are you exclusive?
No, I think that's a Medicare regulation that you have to be notified within a specific time frame.
24 hours.
Within the 24-hour time frame.
It's the same at Fisher Titus also. And you're not signing, you're just signing that you've been made aware. It's not that it doesn't financially
You're not agreeing to
legally.
anything, you're just saying you told me.
Right.
Oh, okay.
So if I'm not able to sign that, who signs it for me? Next of kin?
Yes.
And if I'm all alone and I have nobody, then what?
Well, so we would have our case managers are responsible for calling whoever you have listed and notifying them over the phone.
Okay.
That's what Fisher Titus does also.
Okay.
Just keep going down to line until we find somebody.
Right, okay. And that's another reason to have emergency contact at least with you. So if you can't get a hold of this person, try this person. You know, name 5 people, name 6 people, you know, just depends. I've had people tell me, call my friend, she's always there, my daughters live out of town, you know, so they pick the one that's the most available at that time, or will be most available, so yes. Good. Oh, yes, Q.
Since your doctor doesn't come to the hospital and a hospitalist takes over while you're in the hospital, right? Whether you're an outpatient or inpatient. Now, how does he fit into the picture of making a decision for the patient?
Okay, so her question is, if you're not dealing with your physician while you're in the hospital, and you're dealing with the hospitalist, how do they fit into the picture of this whole observation versus admission? Okay, so I'll let one of you answer.
Basically, when you're coming into the hospital, it's for that acute episode. So even though your regular primary physician is who you normally see and has all your history, the hospitalist still is able to get the information that you're coming in with, the testing and that, and treat what you're in the hospital for. And hopefully being able to get medical history from you. They can also call doctor's offices and get information from them and get information on the medication. So we pull together all that information. So the hospitalist has all that available.
While you're in the hospital, the hospitalist calls the shot?
Yes.
That's scary.
Why is that scary?
Well, my physician knows me, but when I don't know how much communication they share, it's supposed to be good, but I have no guarantee as a patient. I trust my doctor totally, but I don't know. There are certain things that you may not be able to communicate between, the two doctors.
I can tell you that Fisher Titus, that this is the hospitalist, they also call your physician before you leave the hospital. So they let them know what you were in the hospital for, what the treatment was, and what the plan is. So they do talk to your doctor.
It's after the fact though, it's not while you're in there.
It's while you're in the hospital, prior to you being discharged. Prior to you leaving, the hospital doctor calls your doctor.
But during
When
the
you're
time-
when you're admitted to the hospital, the registration staff, I'm not sure how it is at Fisher Titus, but at Firelands, when you're admitted to the hospital, if you went through the emergency room, the ER, registration staff does notify your doctor that you were admitted to the hospital. If there are specific concerns that any patient has and they want their family doctor called while they're at the hospital, they can make that request of the hospitalist as well, so they can have that one-on-one and make sure that they're not missing something, or that, you know, if you have a really complex clinical background and there's stuff going on with you that your family doctor needs to notify the hospitalist of, that's something that I think happens everywhere.
I think the problem with your hospitals or whatever you call them, you're not gonna see that same doctor all the time. Just might come in, the next day you'll see another one, the next day you'll see another one, and now you know what the heck is going on, and, you know, to care less, and they were there.
And that is happening. I think
I
you
know
do
it
see
does.
more than one, yeah. You do see more than one because they do
Because I
take,
went through that.
they need time to rest.
He said, well, we'll do something tomorrow, maybe. I had 3 blood clots. Tomorrow, no. They said I shouldn't be alive, actually. They said I should be dead by now. He said, well, maybe tomorrow we'll think about it.
Well, and I can't speak for hospitalists. I just know I've had forums with hospitalists that are here, and they have told me that they are in contact with your family physician. If if they question anything, they contact the family physician. So the family physician is aware that you are in the hospital, and if they don't agree with something, then the family physician will be contacted and then they will hash that out. So the reasoning for the hospitalist program, again, this could be a whole different forum, but we're talking about it, so I'm bringing it up, is so that your doctor can have more time in his office, spending more time with patients if need be. So unfortunately, the way the healthcare system is working is they want you in and they want you out. Because they don't want the rehospitalizations, they want to make sure things are good, then you're out. Because back in the day, people used to stay in the hospital for what, 10 days for pneumonia? You know, I mean, you don't see that anymore. Because the insurance companies are the ones saying, we got to lay down the law. We got to say you're in and you're out. So it's the same scenario for the doctors that don't come to the hospital anymore. They give that responsibility to doctors that are qualified and specialize in inpatient medicine to deal with that acute problem that you have at that moment. Now, whether it's a good or bad situation, it's unfortunate to have a bad situation. We all know that. We all know that we've been in the hospital and we've questioned many things and many procedures, but that's why we're talking, and that's why we're learning from each other to not have the situations and put ourselves in those situations. So the more you know, the better you do, right? So that's why I like to get the word out there that yes, you're not going to see, pretty much every hospital in the area has hospitalists, correct? Bellevue included, correct?
Our local physicians rotate that.
I see.
One of them takes a week, they rotate a week where they're the hospitalist in the hospital.
Yeah, so anywhere you go.
They communicate between the patient's primary care physicians, I know for a fact, you know,
Right.
yeah.
And it's happening, and it's not always a good thing, but we can try to look on the better side of it and say, now I know, now I can do better. So
Well,
that's
and
how I feel.
even for the patients whose family doctor does still come to the hospital and does see them at the hospital, they're not taking care of you 7 days a week. They also have a partner that they're rotating on and off with. So you're still going to see, you have the potential to see your doctor and their partners. So I don't think that that's new in the world of healthcare.
You're right, that's not new, so. Yes, question.
But if you're in the hospital and you have something, you need a pulmonologist or a cardiologist, things like that, especially if you've seen those doctors over there, then those doctors will take care of you also, correct?
Mm-hmm. Yeah, the hospitalist will consult to have that specialty come in and see you.
So her question there in the back is if you need to see a specialist, pulmonologist, cardiologist, that specialist will come in. It won't be a hospitalist that takes care of all the problems. They're there just for the acute problem while you're there. Same as your regular physician would be. If he needed a cardiologist, he'd call a cardiologist to come in. So yeah. Any other questions revolving around? Yes.
I have a cold in my ear, so I don't know if this was covered.
Okay.
If your family doctor doesn't agree with what the treatment you're getting, does his or her say so have any input? Does he have any input?
Yes.
And would he be listened to?
Yes, I don't know of any of the doctors at our hospital that don't work with other doctors. They may not agree, but they communicate with each other to determine what's going to be best for you.
Okay.
So what's normally written on your discharge papers when you leave the hospital? Make an appointment with who?
Yeah.
So they're going to see you regardless. They're just not going to see you in the hospital. They're going to take care of that situation, and then hopefully you get better and you see your doctor and follow up from there. So if he's not agreeing with an antibiotic that you may have been on or was discharged with, he may switch it at that time. That's why there's always the follow-up. So yeah. Okay, any questions revolving around observation and mission? It was a good panel. They covered it well. Everybody knows better now? So yeah, we'll cut it short, but you guys seem like either you're tired or you just don't want to talk about it anymore. So yeah, so look for the next forum. Like I said, I have it in front of you July 19th. We had a podiatrist coming and a pharmacist and a physical therapist coming. So Good panel also. Thank you.
Thank you.